So welcome back to you all for the final talk of today's meeting, for the meeting in general. We have saved the best for last, in my opinion. We're very fortunate to have Jedd Wolchok close out the meeting before our final discussion. And I think Jedd needs no introduction to all of you here. You know he's a absolute leader in the field of immunotherapy. He's one of the clinical pioneers, but also a pioneer in terms of bridging mechanistic studies and bringing those back to the clinic. Jedd's also a former colleague of mine from MSKCC, and it was really inspirational for me when I was a young scientist starting my lab there to see everything that Jedd was doing firsthand and all of those very early and very promising clinical successes that he was leading there, and he has obviously continued to do that over the decades in between. So with that, I hand over to you, Jedd, and we look forward to your talk very much.
Thank you, Joanna. And I don't think that you saved the best for last. There were many wonderful presentations in this meeting, and it's really a privilege to be part of this this effort. Let's see. So is that showing up okay?
Yes, it is. Yeah.
Okay, great. So as Joanna said, I'm going to focus on checkpoint blockade therapy, specifically on combinations to improve outcomes. These are my disclosures for this talk. You know, as a very brief introduction, I should just remind everyone that, you know, the first of the immune checkpoint molecules that was explored clinically was ipilimumab, that is a fully human monoclonal antibody which blocks CTLA-4. And the rationale for blocking CTLA-4 was made quite clear by Jim Allison, for which he was awarded the Nobel Prize in 2018, and really that is that CTLA-4 plays a non-redundant role in restraining T cell activation once T cells have been stimulated by coordinate ligation of the T cell receptor by the antigen MHC complex, as well as CD28 ligating a co-stimulatory family member. CTLA-4 then translocates into the immune synapse. It outcompetes CD28 for binding to these co-stimulatory molecules, generates inhibitory signaling into the T cell, and therefore serves a function in maintaining immune homeostasis. CTLA-4 ipilimumab blocks CTLA-4. It's a fully human IgG1 monoclonal antibody. It's approved for melanoma as well as some other malignancies, depending upon which part of the world you reside in. The activity of ipilimumab as a CTLA-4 blocking medicine in melanoma, which is the disease that I specifically have the most experience with, is summarized quite well here in work published by Dirk Schadendorf in JCO, now going on 6 years ago. This was essentially a 5-year follow-up of patients from the early phase 2 and phase 3 clinical trials of ipilimumab, and really shows quite nicely that there is a tail on this curve that plateaus at about 20% of patients with metastatic melanoma if they've been treated with ipilimumab. Now, that may not seem like a particularly impressive number, but truth be told, this left side of the slide was what we as melanoma oncologists were used to seeing in the era before the development of checkpoint blocking antibodies, the era before the development of BRAF and MEK inhibitors, that we saw this rapid decline in survival curves with maybe 2 to 5% of people alive despite either single agent or combination chemotherapy. So even though that 20% number is quite low, it really was an important step in the right direction for the whole field and, of course, for our patients most specifically. Now, many of us are aware, this was alluded to in Kunli's wonderful talk before, the questions for it, that there are toxicities that occur along with checkpoint blockade as we disinhibit not only T cells that have specificity for targets on cancer, but also T cells that have specificity for self-organ molecules, and that these cells are being kept essentially in check by CTLA-4. These toxicities can affect almost every organ in the body. They are thankfully well controlled with the use of corticosteroids or rarely TNF blocking drugs or other immune suppressing medicines are sometimes necessary, and are very rarely life-threatening and very rarely leading to long-term complications. The only ones that have really a lifelong impact are those toxicities that affect endocrine organs. In the case of CTLA-4 blockade, the thyroid and pituitary and more rarely adrenal glands can be damaged, and those patients who sustain that may need hormone replacement therapy. In the case of PD-1 blockade, which I'll get to in just a moment, the damage to the the endocrine pancreas cells, can lead to type 1 diabetes, which obviously requires lifelong insulin supplementation. But other than that, the liver, the GI tract, the skin, other organs do seem to recover quite well. And thankfully, there seems to be a disengagement of the anti-tumor activity from the toxicity in terms of the suppressive effects of corticosteroids or other immune suppressing medicines. There does not seem to be a consistent impact on survival in patients who need corticosteroids versus those who don't. And it may be as simple as the fact that the damage is done to the tumor sooner, whereas these toxicities largely occur 8+ weeks after initiating therapy. But there may be differences in terms of the affinity of the T cells, especially those that recognize mutated neoantigens compared with the self-reactive T cells. And this is work that I will not present today in the interest of time, but that was led by a colleague of mine, Dr. Hiroyoshi Nishikawa, from the National Cancer Center in Tokyo, and published in JEM about 2 years ago now. I alluded to the fact that following the success and approval of CTLA-4 blockade with ipilimumab came other immune checkpoints entering clinical trials. PD-1, or programmed death molecule number 1, was the next checkpoint that was exploited clinically. PD-1 was discovered by Tasuku Honjo, and he was also awarded the Nobel Prize along with Jim Allison for his work. PD-1 was discovered by Honjo due to its role in mediating programmed cell death or apoptosis of T cells and T cell hybridomas. That was really Honjo's area of expertise. The discovery of PD-1 by Honjo led other investigators, including Arlene Sharp, Gordon Freeman, Liping Chen, Weiping Zhao, and others, to look at this in the context of cancer and identify the ligands that PD-1 recognizes. As you all well know, under normal circumstances, PD-1 mediates an inhibitory crosstalk between an APC with one of the ligands on it and the T cell. When PD-1 is triggered on the T cell, it, via a SHP2 dependent mechanism, silences signaling from the T cell receptor, which leads to earlier apoptosis of the T cell. Now, in the tumor microenvironment, it was recognized that a variety of tumor cells have evolved the ability to induce PD-L1 on their surface. And this is via a mechanism that was termed adaptive resistance by Suzanne Topalian and Drew Pardol, where a T cell that comes into the tumor microenvironment secretes interferon gamma. Interferon gamma is one cytokine that can induce PD-L1 on the tumor cell, and therefore the tumor cell can defend itself against the T cell by, again, quieting the activation of the T cell through this interaction. Because the PD-1 pathway can play a role in both the local draining lymph node in the case of this APC T cell interaction or in the tumor microenvironment itself, it was recognized to be a very important target for cancer immunotherapy. There are now 6 approved molecules that block this in the US, that block either the PD-1 receptor or PD-1 ligand. I'm not going to get into the immunologic street fight about whether it's better to block the receptor or the ligand, but speaking as a humble melanoma doctor, I'll tell you that blocking the receptor with either nivolumab or pembrolizumab really has equal activity, and we also have seen in combination studies that atezolizumab, when given along with BRAF and MEK inhibitors where it's approved, but atezolizumab has activity in melanoma as well. So I think that in general, these agents have similar activity. Just looking at some early data from pembrolizumab, which is one of the PD-1 receptor blocking drugs. This is data that was originally presented by Tony Ribas and then published by Caroline Robert in patients with either ipilimumab treated melanoma in yellow on this waterfall plot, or ipilimumab naive melanoma in blue. And what you can see is that there is about an equal number of yellow and blue bars, implying that whether or not the patient had melanoma that was refractory to CTLA-4 blockade with ipilimumab, they still could respond with about equal frequency to PD-1 blockade, in this case with pembrolizumab. And that was very nice evidence that even though both of these mechanisms of cancer immunotherapy via checkpoint blockade converge on the T cell as the ultimate mediator of the anti-tumor effect, the manner in which they get there is non-redundant. And that opens up possibilities for combinatorial approaches. And that was really an area that our group dove into along with colleagues from Yale, looking at combinations of ipilimumab to block CTLA-4 and nivolumab to block PD-1 in phase 1 and 2 clinical trials. Ultimately, a phase 3 clinical trial entitled Checkmate 67 was completed, which looked at the 2 monotherapies alongside the combination treatment. This was a worldwide study. I'm going to show you the most recent look at the data, which was at the 5-year mark. And what we can see is that overall survival-wise, the patients who were initially randomized to receive the combination of CTLA-4 plus PD-1 blockade had a just over 50% 5-year survival, compared with 44% for those patients initially randomized to nivolumab alone to block PD-1, or 26% of those patients randomized to ipilimumab alone. And so we see really both of the nivolumab containing groups statistically significantly better than ipilimumab, and a modest difference in the 5-year outcomes in favor of the combination group. The trial was not powered to put a p-value on this, but the hazard ratio is shown here. And it's also important that I remind us that, when I started off and showed you that the historical data for chemotherapy would have shown a 2 to 5% 2-year survival, that we're now talking about 50% plus survival at 5 years. So this is both, again, good and bad. The good is that we've certainly made progress, but the bad, of course, is that we have about half of patients still looking for something better in terms of treatment, and that's where I'm going to spend the second half of my talk. So the other part of this story, which is important for the combination of CTLA-4 and PD-1, is the toxicity. So nivolumab alone or ipilimumab alone has about a 20 to 30% incidence of high-grade, grade 3 or 4 immune-related adverse events. And I mentioned this before. Once we combine these together, we get actually a more than additive effect. We get nearly a 60% incidence of high-grade adverse events. Not a big difference in treatment-related deaths, thankfully, but definitely more of these adverse events. And I should add that there really is no signature adverse event for the combination, but rather more patients are having multiple events. So it's really the same toxicities happening with greater frequency, not different frequencies happening. But this difference in toxicity in the context of the modest difference in survival outcomes, is something that leads to thoughtful discussions between clinicians and patients and their families about choosing really what's the best risk-benefit profile for people to, to settle on when choosing therapy. Now, I'm going to move on to another pathway, which is the OX40 pathway. This is unpublished data, although it is available on a preprint server through the Cell Press Sneak Peek. And this is our work on OX40 agonism as a means to overcome tumor heterogeneity of antigen expression. And I think this is an important concept because all of these T-cell-based therapies are reliant upon expression of antigen, whether we talk about neoantigens being recognized by T-cells that are disinhibited by checkpoint blockade, or whether we're talking about TIL or engineered T-cells. If the tumor cell loses expression of the antigen, that is one very obvious route of escape from this means of defense. And so overcoming heterogeneity, we think, is an important concept to consider. So this is the work of Daniel Hirschhorn, and it really focuses again on this OX40 pathway. And OX40 is, a member of the TNF receptor family. It is expressed on a variety of different immune cells, but is most associated with CD4 positive T cells. And there's ample rationale shown on this slide for why agonizing OX40 would be a reasonable consideration as a therapeutic endeavor. It's important also that I couch this by saying that OX40 engagement as a monotherapy is ineffective in treating established poorly immunogenic tumors such as B16 melanoma. So this by itself is not an effective modality, at least in the model systems that we've looked at. In addition, in the clinic, as monotherapies, these agents have been disappointing. But one message I would like to convey is that OX40 as an example of the co-stimulators, even though it's disappointing in terms of not shrinking tumors by itself in clinical trials, does not mean that this is not an important pathway. As we think about drug development, we need to think about whether these agents are hitting their biologic targets, whether they are enacting the hypothesized immunobiologic effects. I think that all too often decisions are made to kill programs in terms of drug development programs because of lack of the ability to shrink tumors. And while shrinking tumors is the business that we're in, we need to recognize that not every agent is going to be like CTLA-4 or PD-1 blocking drugs, where like by itself in an unselected population, we're going to all of a sudden see activity. So I think that's an overarching message for the next generation of drug development in immuno-oncology is how do we fit this in a mechanistic way and understand whether the pathways are operative or not, and not just cast these agents at the roadside. I'll step off my soapbox then for the moment. So let me just give you an example of melanoma heterogeneity and the challenge that we have. So this is looking at the prevalence of an antigen called TYRP1. This is a member of the tyrosinase family of differentiation antigens that are present in melanomas and melanocytes. It's part of the melanin synthetic machinery. It's also called TRP1. At MSK, we call it GP75 because it was discovered here by Lloyd Old and Alan Houghton and Tim Thompson based upon its molecular mass on a gel. But what you can see in this work done by Travis Holman, Yanyun Lee, Aaliyah Holland, and David Schroeder, that there is quite a lot of heterogeneity in TYRP1 expression in the context of S100 positive melanomas, where you see, there are some melanomas that have very little TYRP1 expression, some that have scattered, and some that are densely and uniformly TYRP1 positive. And so this is the challenge that we're up against in terms of heterogeneity. This is just showing you, how this plays out in terms of reanalysis of data from the Teirosh et al. Science paper, looking at the heterogeneity of this antigen expression across several different patients. If you can see that the heterogeneity quite clearly. Now, in the context of the system that we use to study OX40, we use B16 melanoma, sort of unadulterated B16 melanoma. This is a 21-day-old tumor. And what you can see is that if you treat this with a combination of cyclophosphamide and an OX40 agonist called OX86, and an infusion of CD4 positive T cells that recognize TRP1, the antigen, you can regress these tumors. And these T cells come from a transgenic mouse that was generated by Nick Restifo's group at the National Institutes of Health. What you also can see is that if you compare B16 melanoma with a variant of B16 that does not express the target antigen, nor does it express MHC molecules, that the B16 negative variant does not respond to this triple combination therapy. However, a 50-50 mix of the two tumor cell types within the same tumor mass does almost always regress, whereas a tumor of each kind on opposite flanks, the B16 regresses, the B70H1 does not. So what this shows us is that there is no antigen spreading, but that there is a bystander killing activity. And now we're digging into the mechanism underlying that bystander killing activity. We also have noted that in addition to the well-recognized hypopigmentation of coat that occurs in mice treated with antigen-specific immunotherapy for melanoma, these mice treated with this combination therapy develop a granulomatous inflammation of the ears, the snout, the periorbital, and perianal areas. And these are the areas of non-haired skin in the mouse where there is the densest population of melanocytes, which bear the target antigen. And so this is really an on-target toxicity. You can measure this simply by looking at the ear thickness. This is looking at just the cells, those TRP1 cells and cyclophosphamide with a control IgG. This is the triple combination. You can see that the OX40 agonist really mediates much of this combinatorial effect in terms of the ear thickness and also the tumor activity. When we look at when the T cells are necessary, if you deplete T cells early at day 3, you lose the anti-tumor activity. But if you deplete T cells late, you preserve anti-tumor activity. Same as for the ear inflammation. If you deplete T cells early, and this is really depleting the CD4 transgenic T cells, because these are sometimes done in rag knockout mice, so there isn't a repertoire to consider. And if you deplete the T cells late, you still get the same ear inflammation. So T cells are necessary early, but there's another cell population that's clearly necessary later on. Now, when we look at what other cell population to choose to look at, we analyzed protein extracts from the inflamed ears and showed that there was an accumulation of signals from innate immune cell types in a time and OX40 dependent manner. implying that perhaps macrophages or neutrophils were participating. And indeed, when we look at the inflamed ears of these mice, staining with either CD11b or Ly6G, we can see an OX40 dependent and time dependent accumulation of either monocytes or neutrophils in the ears of these mice treated with the triple combination. And then we ask the natural next question of what happens if you deplete neutrophils with anti-Ly6G. And so if you look at the ear thickness, you can see that anti-Ly6G will decrease the ear inflammation in the triple combination treated mice. However, if you look at B16 melanoma in these mice, the anti-Ly6G has no impact on the tumor immunity. Now remember, B16 melanoma is uniformly positive for TRP1, so we don't really need a bystander killing activity. However, if we do the same experiment with Ly6G in these mice that bear the chimeric tumors that have B16 and B78H1 in a 50-50 mix, you can see that we now are losing tumor control when we deplete neutrophils. So the lowly neutrophil, which is often considered unimportant and in fact sometimes harmful for tumor immunity, may be playing a role. And this is the hypothesis that we have about what may be happening in terms of an inflamed tumor initially being infiltrated by T cells, that leading to the recruitment of neutrophils, neutrophils through a variety of mechanisms, including the construction of neutrophil extracellular traps, lead to tumor control as well as adverse events in both people and mice. I'm going to spend just a couple of minutes before I finish talking about some work that was just published yesterday, or actually 2 days ago, by my colleague, Roberta Zaffasati, who just opened her own independent lab at Weill Cornell. This is work looking at a new mechanism for CTLA-4 blockade in its role in destabilizing Tregs in the context of the glycolytic microenvironment. So as many of you are aware, tumor glycolysis has now been identified as a barrier to anti-tumor immunity, and tumor metabolic adaptation is emerging as a major mechanism of immune resistance. A high rate of glucose consumption and lactate production as a result of that by tumor cells in a hypoxic environment of the tumor restrict nutrient availability for effector T cells, which also rely on glycolysis for their proliferation and their effector function. Now, our working hypothesis really was that a highly glycolytic tumor microenvironment, would lead to intratumoral negative impact on intratumoral T cell survival, expansion, and effector functions, and therefore an inhibition of anti-tumor immunity and resistance to checkpoint blockade. And so we hypothesized that an inhibition of tumor glycolysis could restore anti-tumor immunity and increase the likelihood of response to checkpoint blockade. Okay. Shown there. So the questions that Roberta addressed in this study were, how does tumor glycolysis affect checkpoint blockade therapeutic activity? If that's the case, which immune cell types are impacted the most when tumor glycolysis is hampered? What is the mechanism underlying improved immune response? And is the mechanism relevant to the human setting? Okay. Now, we generated a couple of model systems for proof of concept, and these were to selectively inhibit glycolysis in tumors and assess the response to checkpoint blockade. We knocked down the critical glycolytic enzyme, lactate dehydrogenase alpha, LDHA, in tumor cells using 4T1 and B16 as the models, using either scrambled or siRNA specific for LDHA. And these two tumor models are obviously refractory and aggressive. And by doing so, we found that glycolysis using seahorse here was slowed down and glucose consumption was reduced when LDHA was knocked down in both the B16 and also the 4T1 models. We then treated these tumors with checkpoint blockade in vivo using anti-CTLA-4 or anti-PD-1. And with the 4T1 tumors, I should point out that we used a neoadjuvant regimen with surgically resected glycolysis-defected tumors 3 days in after control. And also 4T1 scramble tumors to equalize tumor burden on the day of the surgery. So we used this 3-day window to make sure that the tumors were about the same size. We found that CTLA-4 blockade, in particular, was really more effective when used in the neoadjuvant setting in mice bearing the glycolysis defective LDH knockdown tumors and delayed primary tumor growth in mice bearing the LDH knocked down B16 tumors here on the right side of the slide. In addition, mice that completely eradicated the glycolysis defective tumors upon neoadjuvant anti-CTLA-4 in the context of the 4T1 controlled a second tumor challenge shown here, even with the more aggressive LDH competent control tumor type, indicating the development of long-lasting immunity. So we then wanted to go on and ask which immune cell types are impacted the most. So we looked at various different immune cell types, and we looked for changes in frequency of lymphoid cell subsets, didn't find any. We looked for changes in the frequency of myeloid cell subsets, didn't find any. But we did find a change in T cell function. Specifically, the most consistent change we saw, which is shown in this blue rectangle here, was an increase in Th1 cytokine production by CD4 cells, especially Tregs, which were now producing interferon gamma. And this is a signal that we had seen previously using our GITR studies. This was other work that Roberta published about 2 years ago, where Tregs that begin to make interferon gamma show signs of losing their lineage commitment. So this is the model that we came up with, that in CTLA-4 blockade and glycolysis high tumors, really relies upon the suppressive effects of Tregs, and that there really is very little effect of CTLA-4 blockade on Tregs in these glycolysis high tumors. But in glycolysis low tumors, specifically those in which the LDH had been knocked down, we now see that they become susceptible to the effects of CTLA-4 blockade. They lose their lineage stability, and they begin to make interferon gamma. So is there clinical relevance? Well, there actually is some. We looked at heterogeneous tumor glycolysis effects in both melanoma patients and also in mice that were bearing the tumors that either were scrambled, these were the 4T1s, or knocked down for LDHA. And we saw this relationship between the activity of the glycolytic pathway and the sort of effector pathways of T cells. And so we see that there's this nice concordance between the glycolysis and the immune effector pathways that we've been studying. So in conclusion, CTLA-4 blockade inhibits Treg suppression in a glucose-dependent manner. It improves immune cell fitness in glycolysis low tumors. And it may be, we are seeing now that CTLA-4 blockade may be best exploited to treat glycolysis low tumors in combination with inhibitors of tumor glycolysis. I'm going to finish up there. I'm sorry that I went a little bit over and rushed at the end, but I wanted to leave some time for questions. This work was really co-led by myself and my long-term colleague and co-director of the lab, Taha Mergoob. I highlighted the recent work of Roberta Zapasati and the unpublished work of Daniel Hirschhorn. The CTLA-4 and PD-1 blockade studies in humans were really co-led by myself, Maggie Callahan, and Michael Postow. This is what our lab meetings look like, as I'm sure many of yours do now as well, that we believe that Zoom is the adaptive resistance mechanism for SARS-CoV-2. I should actually point out that one of our lab members, Lucas Krakenball, was actually deployed by the Swiss Army into Kosovo and participated in the lab meeting. He's in the medical corps and was deployed to fight COVID. And so we're very happy to have him. This is some of our other lab members. Of course, our funders at the bottom. And because we use clinical specimens, special thanks to patients and their families. Thanks again for paying attention, and I'm happy to answer some questions.
Wonderful. Thanks very much, Jedd. Maybe I'll start with the first question for the last part of your talk, this work that was just published in Nature. So the question I have is, in the context of the glycolysis low tumors, where you see a shift, a de-differentiation, whatever you want to call it, for this transition from Treg cells to T effector cells. Can you say, to pardon a pun, if there's a sweet spot for that effect to happen? So is there a point of commitment where you can't make that change? Or do you think that any Treg that's infiltrating the tumor is amenable to being reprogrammed in that context?
It's a really good question, Joanna. So I thought you were getting to a sweet spot of like, is there a level of glucose? Because we did show that there was
that too.
That's the part that I kind of rushed through at the end, but there is a glucose concentration dependency to this. So the more glucose that's left back in the microenvironment, because the tumors that are not using it, the more the Tregs are amenable to this loss of lineage commitment. But I don't think that we've looked yet at the question that you're getting at, is when does the Treg become too hardwired to be reverted? So it's a great question, and I think we need to dig into that.
Okay, so next question is from Leila Akari. Leila, we'll see if we can connect you up to ask the question live.
Yeah, do you hear me okay?
Yeah.
Yes, I do. Thank you.
Hi, Jedd. Wonderful talk. Thank you very much. I have a question also related to glycolysis. So if you wanted to block glycolysis in patients, of course, you cannot knock out LDHA. Would it be an opportunity to change diet and try to enforce ketosis, for example, in patients, see if that would be beneficial? And my and then I have another question if possible, but please go ahead for this.
Yeah, no, I'll definitely take both of your questions. But I think that it's a really important question, and one that that patients ask us all the time, right? Like, should I not be eating sugar? I think the challenge, of course, is that in this tumor microenvironment, the effector T cells need the glucose. Right. So what we really need to do is to have a selective effect on the tumor cells to prevent them from performing glycolysis. That's the real challenge, that there's a selectivity that's necessary, because what our work showed is that the less glycolytic the tumors are, the more glucose is left behind, we hypothesize, in the tumor microenvironment for the Tregs to have access to. And it's those Tregs that have sort of sufficient glucose, because the tumors are not using it. Those are the Tregs that are most sensitive to this loss of lineage commitment. So I think if there were a way to enforce ketosis just in the tumor cells, then I think we'd be in business.
Yeah. Okay, and if I can, another question, Joanna. I was wondering if, when you looked at this change in metabolism in the tumor cells, have you also been able to look at the coevolution in the stromal and innate immune cells, particularly, see how they would potentially adapt and in return affect the T cells?
It's a great question. And I think it gets to something really that Lillian started the day talking about, that there's really, there are many cell types, and there's a lot of dynamic effects going on. But so we have not yet looked at those, but for sure they must be participating.
Okay, so there's a number of remaining Thanks, Leila. A number of remaining questions. I'm going to try and get through those in a logical order relating to the questions that have been asked already. So an anonymous question, do you think that antigen presenting cells play a role in the recommitment of Tregs to T effector cells?
That's a great question. We have not really looked at that, so I don't know. I mean, many of our studies were, I mean, one of the in vitro studies was only done with really isolated T cells and tumor cells, and unless you consider a tumor cell to be a poor APC, we haven't really looked at that yet.
Another question relating to the glycolysis aspect of your talk. Given the prominence of FDG PET imaging, what are your thoughts on the role of PET imaging in the IO space, either with FDG or with other tracers? And this is a question that I think we can also carry over to the next panel discussion. What are your thoughts on the many different imaging methods, including some of those that have been discussed by Lillian earlier today?
Yeah, I think that it's a really important question, and I think it's something that we talk about with patients all the time, that PET does not just pick up tumor cells, right? That the PET can actually pick up immune cells. And actually, it's something that we were chatting about before the conference started this morning, that we're now seeing PET scans, FDG PET scans, lighting up, if you will, in lymph nodes draining the COVID-19 vaccination sites. And so, you know, it's quite clear that FDG PET is not just identifying tumor cells, that it's also identifying T cells. But the question, of course, is how do we disengage those two signals when we're trying to measure an anti-tumor activity?
Yeah, that's an interesting deconvolution challenge, let's say. Okay, I'll see if we can do, let's go to the next question. This is from Joanna Pozniak. So if Joanna gets connected, she can ask the question, or Joanna perhaps. If she's not coming on in the next 2 seconds, I'm going to have to ask the question. Okay, thanks for the very interesting talk. I wanted to refer to the high toxicity of the combination of anti-PD-1 and anti-CTLA-4. Of course, this is a question that you have indeed looked at. Are there considerations for giving these therapies to melanoma patients in a sequential manner?
Great point. It has been looked at, and because of the long half-life, not necessarily the circulating, but more the biologic half-life of these agents, the toxicity is not markedly different when you stagger them, because the effects are quite long-lasting.
Okay, there's another question also relating to FDG scans. I think Julia Hobart, if you can hold on to that question and come back to that in the panel, that would be excellent. Last question I'm going to ask is another anonymous one. Great talk, indeed. I would like to ask your opinion regarding other types of adoptive cell therapy. What's your opinion about, well, this could be a very long answer, about CAR T cells, CAR NK cells, CAR technology in general? Do you want to hold that thought and take it 5 minutes from now to
why don't we do that? Why don't we take it into the panel discussion?
Okay, so you have a few minutes to chew that over, Jedd. Yeah. Okay, so with that, thanks very much to Jedd. Wonderful talk as always.